Hi, I'm Eliza Buyers, one of the adolescent gynecologists here at Children's Hospital Colorado, and I'd like to talk to you about one of the most common reasons that I see preteens and teens with complex medical issues, and that is to talk about their menstrual periods and consider options for suppression. There's often lots of anxiety about puberty, and it can be so helpful when we provide guidance on the timing of events. For girls, the sign that the ovaries are turning on and making estrogen is the breast bud. It will then be 2 to 3 years of estrogen exposure on the uterine lining before the first period occurs. Talking about puberty is also a great time to touch base with caregivers and patients on some important topics. For teens with developmental and physical disabilities, issues of body boundaries, privacy, and communication can be challenging. But know that as their health provider, you are the perfect person to hear about any concerns, as well as affirm that the physical and emotional changes that come with growing older are normal and healthy. In terms of talking about periods, it's always great to review what's considered normal for timing, cycle length, and interval. Like their peers, girls with complex medical needs also can have issues like heavy bleeding or amenorrhea that may warrant further investigation. Here are some of the most common reasons that families are interested in suppression. Hygiene and behavior concerns top the list, but for most of our patients, it is a combination of factors that leads them to initiate treatment. The first thing to know about menstrual suppression is how it works. Estrogen is made by the ovary from the start of puberty, and it causes the lining of the uterus to grow thicker and more vascular. Progesterone, which is only made naturally when someone ovulates, matures the lining of the uterus. It turns out that when progestins, which are synthetic versions of the hormone progesterone, are given over time, the lining of the uterus becomes atrophic and does not build up. And this means it's safe not to have periods. Here's a chart from our website that shows options for menstrual suppression. The best one for your patient depends on their preferences, along with consideration of their medical history and treatment goals. Let's do a quick review of the most commonly chosen methods. And we can start with a popular choice in our practice, and that is the progestin-containing IUD. This small T-shaped device puts medication directly inside the uterus. Menstrual bleeding significantly decreases or stops entirely. Cramps and pain are also reduced. The IUD is approved for 7 years, at which time it can be removed and a new one placed. Our patients with developmental delay will usually have their IUD placed under anesthesia. Another common treatment option is norethindrone acetate 5 milligrams each day. This progestin-only medication induces endometrial atrophy and suppresses ovarian follicular development. Because it does not contain estrogen, there are very few medical contraindications, and it is usually well tolerated. Although it has a very similar name, this medication is not the same thing as the progestin-only birth control pill, which at a much lower dose of norethindrone does not reliably suppress ovulation or bleeding. Combined hormonal methods, the pill, patch, and ring, contain estrogen and progestin. An added benefit of these methods is that they also improve acne and hirsutism. Estrogen-containing methods are contraindicated in patients with an existing predisposition to thrombosis. For example, a known inherited thrombophilia or a very complex cardiovascular condition that increases this risk. For menstrual suppression, the pill should be prescribed in continuous dosing, which means that an active pill is taken at the same time every day. When or if breakthrough bleeding occurs, a 4-day break should be done, and then the medication started again. It can take users up to 6 months to achieve amenorrhea. Depo-Provera is an injection given every 3 months. Periods may stop right away, or it can take 2 to 3 injections before bleeding is suppressed. One of the concerns with Depo use is that estrogen levels generally run a bit lower when on this medication, which means that over time, there is concern for decreased bone density. It's a good idea to steer away from Depo in teens who already have significant risk factors for low bone density, such as they are non-weight bearing or have used chronic steroids. That said, we do support the use of Depo when, after counseling, it is still the best option for the patient and their family. Injections can be given in the clinic or at home by the patient or their caregiver via a pre-filled syringe. Finally, the subdermal implant. It contains only progestin and is safe for almost everyone. It is inserted by a simple 30-second procedure, which may or may not be tolerated in the office by patients with developmental delay. The implant thins the lining of the uterus. However, unpredictable bleeding is common, and only 20% of users will experience amenorrhea. The implant is a great choice for contraception and suppression of ovulation, but an additional method such as a pill or norethindrone acetate may have to be added in if suppression does not occur with the implant alone. The most common side effect with all methods is bleeding when it is not wanted or expected. For all treatments except the implant, breakthrough bleeding will improve with continued use. It's important to reassure families that it can take some time to induce endometrial atrophy and achieve amenorrhea. It is also always an option to try an alternative. There are several treatment options that should be avoided in young people. Menstrual suppression should not be initiated prior to the first period. Tubal ligation is unnecessary, as there are less invasive and non-permanent options for contraception. And the same can be said for hysterectomy, which should be considered only when gynecologic indications are present. So to sum it up, menstrual suppression when periods are a problem is safe and effective. We recommend using medical considerations and individual preference to guide treatment, as well as a hefty dose of flexibility and humility given the complex medical issues faced by our patients and their families. We encourage you to check out our patient and provider resources at cupag.org. Thank you for watching this video, and please reach out to our GYN team when we can support your work in caring for adolescent patients.